approximately 60 to 75 cases of arrhythmia, life-threatening, admitted to in our hospital and various divisional hospital. Around we are receiving post cases, and some who have already aborted their life-threatening, they came to us with so many ECG strips, and sometimes they are coming to in our hospital. So these two patients were kept, for one for the wide complex tachycardia, and second case is the narrow complex tachycardia. So arrhythmia is basically anything deviation from the rhythm, and normal sinus rhythm, and it may be bradyarrhythmia. So many previous lecture here we have dealt with bradyarrhythmia. Today we have kept for the tachyarrhythmia, and this is the one of the challenges for the clinician regarding the tachyarrhythmia and its management. So very commonly, one thing is that it required emergency in minutes, sometimes in seconds, dealt with minutes and seconds, not in hours and days. So here, first point is that whether we have to, how to diagnose pinpoint. So wide complex tachycardia is basically when your QRS duration is more than 0.12 second onward, and narrow complex tachycardia when it is less than 0.6 second downward. So what happens in wide complex tachycardia? First, this is the case of wide complex tachycardia. Whether we have to, the most common what kept in our mind, there are three differential diagnoses kept. One is ventricular tachycardia. Second is supraventricular tachycardia with aberrancy. This aberrancy could be either with fascicular block with RBB, and second with the WPW syndrome. So these are the three differential diagnoses of wide complex tachycardia. Now these three, how to deal with VT, or it is the SVT with aberrancy. Just last week we have one scleroderma patient, and that ECG we have kept or not? You can show that ECG also. That patient came with the VT versus SVT. It was a big debate. We have last 7 to 10 days we are debating whether because it was a wide complex tachycardia, and patient was scleroderma having fixed type of pattern of that. So SVT with first, what are the pinpoint for the VT? Number one, it will be wide complex tachycardia. Number two, that there should be AV dissociation. Number three, that there should be the fusion beat. There should be the, whenever there is a fusion beat, AVD, when fixed axis, if you look at the V1 to V6, if in a same axis, either positive or negative, favor of VT. Then the QS pattern in V5, V6, pseudo, if there are 7 to 8 algorithms, most common we are following now, present time, Brugada algorithm is there. So that is there are points whether we have to go for the VT versus SVT with aberrancy. Now if it is a SVT with aberrancy, now how to pinpoint that it is SVT with aberrancy? Look for the patient's clinical history. If it is less than 25 or 30, less than 40, no structural heart disease, then the favor of your SVT. More structural heart disease, more scarring, post-myocardial infarction, more favor of the VT. So VT versus SVT with aberrancy is a big debate, and it has to be picked up by the thorough history, ECG, background, echo, and all these points we have to deal with that. Second is that simple is the last, just day before yesterday, one lady from Santoshpur came in completely collapsed state. Dr. Paul is here or not. Luckily, there was a big raining. We were sitting in 6:45, and that time 3 or 4 son is brought in a state of absolutely collapsed, whole body sweating, no BP, no pulse. We were there, immediately first checked the blood sugar, it was on very high, then checked done the ECG, it was 250 it was going on, and plus around 2 hours She felt severe palpitation and syncope, giddiness, pre-syncope, and patient brought to in a stage of complete collapse, and immediately putting a lifeline followed by we have given adenosine. I gave 2-3 adenosine in casualty, and immediately patient brought to back to rhythm and absolutely all right. Everything was all right. She is now in ICU 3. So AVNRT, that SBT is present in 10% of the population, and luckily last 12 years of my tenure here, we have seen more than around 300 SBT in our hospital, and not a single casualty happened. And most of the time, if we forget the diagnosis, we are not flinching diagnosis, and I have seen so many times we have started dopamine. BP is there. Because of the low BP, we are giving dopamine inotropes for aging, and the cause was high rate. So sometimes it is a very difficult to, in that situation, we will further elevate the rate. So AVNRT, basically SBT, is a very common in society, and if somebody is coming to casualty with high rate, look for the ECG, look for narrow or wide. If wide, be aware, it is more danger. If narrow, think what should be the cause. Now for details, if we zoom our vision towards the SBT, the 3 common causes are occurs. One is the AVNRT. This is our case here. In this patient, if you look, this is the case. AVNRT is basically how to deal with AVNRT of that. AVNRT, AVRT, WPW, atrial fibrillation. These are the 4 common causes for the narrow complex tachycardia. Whether the treatment is now the drug of choice, first how to diagnose, because P and QRS are engulfed each other. Here we are seeing in the higher side with down 2-3A. If we look for the V1, there is a pseudo R and pseudo S pattern and fixed. And P is engulfed in the QRS, and AVRT, particularly P comes after the QRS, and if it is the WPW, then the short PR, delta wave, and wide QRS. These are the tribes for WPW. There are so many drivers in railways, particularly young boys, because WPW present in 1 to 2% of population, and they used to come. His normal ECG is WPW pattern. I know few of our staff's husband, sister's husband, he was WPW syndrome. So normal WPW syndrome exists in society. If it remains sometime it fires with the arrhythmia, but sometimes it remains in the society. So WPW syndrome presenting with PSBT is also sometime happening, and so many times we are getting this type of. So in our case, common arrhythmias, narrow complex, wide complex. Narrow complex, most common arrhythmia, atrial fibrillation. Narrow complex, atrial fibrillation, the pinpoint is that it is the irregular rate. If you are seeing QRS axis in various changes with that, and there is a gap, it is favor of atrial fibrillation. Post-surgery patient, most common is of course valvular ischemic heart disease, cardiomyopathy, infection, post-surgery, dyselectrolemia, metabolic acidosis, sulfurous. These are the common cause for the atrial fibrillation. So atrial in geriatric age group, 75 plus, most of them will live with the atrial fibrillation. Number 2 arrhythmia, narrow complex, is the regular tachycardia, that is the PSBT, that we have built here. And third, when we are going in the wide complex is the ventricular tachycardia, most common. Now, this is the normal. There are, if BT, 3 successive VPC, 3 successive, is defined as BT. If it continues for 30 seconds, then it is the sustained BT. If it is less than 30 seconds, it is non-sustained BT. If in single lead, all the morphology are same, it is your monomorphic BT. If different morphology, it is a polymorphic BT. So monomorphic BT, most common cause is the scarring myocardial infarction. Here in our patient, there was a early myocardial infarction leading to first presentation was the BT. Here, that's why this basically this patient we kept for our PI for showing that is the first presentation VT without chest pain. That was our purpose. No chest pain, only rust, having history of ECG or VT, defibrillated, back to rhythm, early to double blockage. That was our message. But normal day-to-day life, generally other cause are scarring, VT, and dyselectrolemia, huge change in hypokalemia. But monomorphic VT, most common cause is the hypokalemia, hypomagnesemia, different drug induced. Dr. Samandra, you remember one trazodone induced VT Appara, we have defibrillated, saved his life. So sometimes drug induced to prolong the QT interval. Cortisone, sometimes so many other procainamide group, earlier it was digitalis. These are the common culprit, and most we have lost post-surgery, some patients, huge surgery, hypokalemia, VT, polymorphic VT. Now how to pinpoint that polymorphic VT was basically known as torsionist dyspointis, TDP. TDP is basically French word, means twisting around the axis. So if single strip will clinch the diagnosis of TDP, if you are seeing the morphology in a single lead is changing wildly with the axis around the lead. So within a fraction of second we can clinch that this is the torsionist dyspointis and there is a huge electrolyte imbalance, and this is purely being treated by the correction of electrolyte by IV magnesium, and there are separate things. Two separate cases in last 12 years I have seen in this that I will mention, and that is reported in various. One is Brugada syndrome. I remember one boy from Kharagpur came to our hospital, and that is a young boy, and that is a diagnosis as a VT, and the cause was the Brugada syndrome. Now Brugada syndrome last 10 years throughout the world, so many parts had been going on this in a school health scheme. So what happened in Brugada and what are the criteria of Brugada? Brugada syndrome is basically the RBB pattern ECG with ST elevation in V1, V2, V3. These are the peaks pattern, and it was seen in so many parts of the Southeastern Asian population, in Mongol population, particularly Buddhist, Thailand, even early part of our Sikkims, then the Nepals. So many cases, young boy in monk monastery, they are living all suddenly they are dying. So they have thought what can be changed, and it was seen that there was a basically RSR pattern in the V1 with ST elevation, and young boy around 15 years had suddenly having gotten SCD, sudden cardiac death, and so that has been diagnosed by this Brugada, and this syndrome was one case from that we have diagnosed Brugada, and that has been then planned for the ICD.
What is the cause?
Brugada is a genetically SCN gene deficiency. It is a basically sodium channelopathy in the myocardium, and that is the basically autosomal dominant disease. And so it runs in the particularly fixed race picked EF. But now last so many young death happens in, so it has been highlighted.
What is the treatment?
Treatment is the basically ICD. First you check, there are three groups of Brugada. One is the confirmed Brugada, second is the probable Brugada. And so you have to check the test, the provoking test through ECG, through the challenge, flecainide challenge test, and from the electrophysiology study. Confirm it, put ICD. So that is the young boy we have treated. And second boy is our son of one VT we have treated in ICU here. Particularly, he was a Durgapur student engineering second year student of Durgapur Engineering College. His father is Souvik Das. Dr. Saha remember his son, one accounts fellowman who we have sanctioned through the railway board, and that ICD of that his boy was having this VT, and what happens, he was one wearing the mosquito with night time, just he was feeling palpitation. So he came to our hospital, and next day I did the echo, it was found normal. Second day, then I thought, but ECG echo there was a RV mildly dilatation, first time. but basal ECG was normal. So this SOBIC, the case is very interesting. Then the next time, okay, he went back, and next time I told him if there was any problem, immediately you do one ECG. Then second time he was near in Kalyani, and when he was having palpitation, he went to immediately Kalyani hospital, and whether this graph was showing the breathing. Immediately they given him IV Corderon and made him to back to sinus rhythm, and again came to here. This time again we did the echo, was RV dilatation. Then our next plan was, we thought some rare causes, a young boy, a 18, 19 years boy with VT and evidence-based VT. First graph, no VT, second time. Then we did the MRI of heart. And MRI of heart was showing a very rare cause, that the arrhythmogenic right ventricular hyperplasia. Last time we presented this patient to API forum. And it was a ARVC, arrhythmogenic right ventricular hyperplasia. Luckily, last 12 years we have got 2 ARVC cases, and one we presented in 2010 and 2011 में this SOBIC case. And then the patient was already been sanctioned through railway board, and it was 3.5 lakhs rupees ICD, was implanted by Dr. Ravi Kishore, electrophysiologist in R.N. Tagore Hospital. Last 2010, he completed now, he got the duty, already job, he is already all right now. And his father came just 3 days back, and he want to meet us for regarding for this good news. So ARVC with VT is one rare cause of VT. Brugada with VT is a rare cause of VT. And common VT, ischemic VT, we have seen it here. And many dyselectrolemia are the causes of the VT. So these are the VT, white form VT or SPT. Any arrhythmia with life-threatening, drug of choice is now defibrillated. So AED and DC shock is now being put on most of the places, in public places, even in railway platform, in the OPD, in ye, automatically just put this switch on the machine. I've seen one of the sportsmen died in some footballer was dying in the ground. His picture was shown in national television. Everybody was standing behind him. And if he could have even given the 2-3 thumb, and his life could have been saved. So that is the message for sudden, sometime BTPF and leading to that. Sometimes even one cardio, that condition is, suppose 2 players are running each other, and only elbow of one is hitting with a strong with the second one, it will lead to sudden breathing. That has been reported, and if that time even
where it will hit the chest,
or some cricket ball suddenly hitting the on osteoporosis, that is very typical of it. It is also cause of the breathing sometimes. So that should be kept in mind. So message is very simple. Tachyarrhythmia is a basically life-threatening situation. We have to take the challenge and pick it, fix it, and treat according to. There are many drugs, we don't want to go in detail, but it is by the thorough immediate action we can save the life. Now, if it is a reversible cause, if it is a terminally irreversible cause, then the result definitely comes discouraging. But if it is a reversible cause, definitely we can get it. Thank you, sir. Any regarding any Dr. Banerjee? Any questions?
Thank you for explaining so nicely.
But generally happens, it comes and it is a part of the most of the case.
What happened to the Brazilian footballer junior who died on the field after being colliding with Subrat, the goalkeeper?
Yes, that's why we want
that
to
is what
be
this thing, bronchocardio, what you are calling.
There are 2 to 3 causes. Sudden death in young athlete. 3 causes are, we have when analyzed the causes of sudden death, SCD, in athlete on ground. 2 clear. Most of them are, it is reported to be hypertrophic cardiomyopathy. And hypertrophic cardiomyopathy patient inside, he was not diagnosed earlier and got suddenly over-exertion and leading to death. In that time there is no heating or gaming. Generally, HOCM was reported to be most common cause on young death in Yemen if remains undiagnosed. Second number, long QT syndrome. Long QT syndrome is basically familial running cases. Whether people are young boy suddenly suppose in school reading suddenly death. His parents started shouting at principal, teachers even didn't did it. But it was basically part and curriculum of school health. In Western countries they did the after Bugadas reported so many times it was been that you have to do one ECG also for it now. But basically if there is any problem for the boy giving you breathlessness or that, in that time in a school health program we have to go for thorough cardiac evaluation, at least keeping the murmur. If there you are getting any murmur, then if we have to go for detail about the systolic murmur evaluation. Normally we ignore in children, but if they are giving this, so that is one way for prevention HOCM, for early detection of that case. And other causes, there are some rare combination of long QT syndrome, HOCM, and then the exertion. These are the common. Generally, ischemia is not a cause in young athlete death. Thank you, sir.